Good morning, and I would like to thank the organizers and the chairperson, the Merck, for giving me this opportunity to present my case on one of the low responders. It's a session just before the tea break, so I hope not to put any of you into sleep and just put you into some little bit of thinking on differential aspects of stimulation. These are my disclosures, and this could be different, and individual cases are already different. And my previous speaker has already given an excellent, elaborate talk on management of low responders, so I wouldn't have to speak anything much on selecting the stimulation protocols and what is good. And of course, but I do believe in treating a patient with low response with adjuvants. Of course, there are RCTs, there are many studies saying that it may not help, but for the patient, I think on a psychological front also, it gives them some time to prepare because the treatment is really long. And as my previous speaker has already told, we do counsel our patients saying that you may require 1 to 3 cycles when you come with a history of low response. So in that time, maybe the coenzyme Q10, DHEAs, and even other alternate therapies like acupuncture too could be tried. So I'll be directly going on to presenting my case. There was a couple who's aged 35 years, the wife aged 35 and the husband age being 37, who were married for 6 years and had been trying to conceive for 5 years. So they had been having treatment for the last 3 years, and among the patient history, what was told to me was that the male partner was diagnosed to have asthenozoospermia and the female had a low ovarian reserve, the AMH being 1.1 nanogram. So coming on to the female history, she had attained menarche at 11 years. She had relatively short cycles occurring once every 25 to 27 days, lasting for about 3 days, being regular in nature, not on any medications, no known illness, and nothing contributory from the family front with a BMI of 28. And on coming on to the male history, his counts were normal but with reduced motility, that is asthenospermia. Nothing else commentable except that the BMI was 32 and he was a regular smoker. He said he had cut down, but still he was smoking about 2 to 4 cigarettes per day. So according to whatever the history was given of the previous treatment, they had a few cycles of timed intercourse. The husband was also treated with antioxidants for almost 2 months. Since they were not conceiving, after a year a HSG was performed which revealed that it was a unicornuate uterus with 1 normal patent right tube. They were offered 2 cycles of IUI, probably owing to the asthenospermia, and in which they failed to conceive. Subsequently, the couple were offered for an IVF. Before she came to us, she had already undergone 2 cycles of IVF with no success. So in one cycle, she had undergone an antagonist protocol, and in the other one, she had undergone an agonist protocol. If you see, the AFC were comparable in both, and though the estrogen was higher in the agonist protocol, the number of oocytes that were obtained were only 2 and 3, the mature oocytes 1 and 2. Unfortunately, in the first attempt, she had no embryo transfer, and in the second attempt, though she was counseled that she was having a very poor quality blastocyst, she had opted for an embryo transfer, knowing the risk, but she failed to conceive. These were the doses of the gonadotrophins that she had received in the first and the second cycle. The number of days of stimulation were not significantly different. In her antag cycle, she had received a dual trigger, and obviously in an agonist cycle, she had only received the HCG trigger. She had gotten us the pictures of the scan on the day of posting. If you see in cycle 1, there were many other small follicles with a low FOI and having only 1 dominant follicle. And in the cycle 2, we can see 2 dominant follicles, and the others are really relatively small. So keeping all this in mind, we decided to reevaluate her. Her AMH turned out now to be at 0.85, which had further reduced from what it was before. And on day 2, her FSH was found to be 13.5, LH5, estrogen 65, because there was already early recruitment with the largest follicle being 12, and it was a very asynchronous cycle. The semen analysis revealed that the total motility, rapid motility, as well as the normal forms, all 3 had reduced parameters, though the counts seemed to be normal. So we did make some attempts on cycle synchronization, and OCP didn't work because the FSH went way too high, and estrogen treatment also didn't work well in her case. Again, she came back with asynchronous follicles of the same nature as what she had come. So then we decided that we're just waiting till she ovulates, and we had documented ovulation on the 10th day of her cycle, after which progestins were offered. 12 days later, we did a scan, there was no corpus luteum, we stopped, and 3 days later she got the cycle. And in the meantime, of course, we had given adjuvants to her, and even her husband was treated with antioxidants. We had also conducted some tests. We had done the FSH and LH polymorphism for her, which turned out to be positive in her case. So on day 2 of the coming cycle, we understood that probably this is the best that we could get after waiting for 2-3 cycles. Her FSH was 11, the LH was 3.1, her estrogen level was 39 picogram per ml. We had about 4 to 5 follicles of similar sizes between 7 to 8, one of 9.5 and one of 6. So we thought that yes, this is the best that we can get, and we decided to start the stimulation. So in earlier cycles, she had received recombinant FSH alone in the start of the cycle, and since we had seen that she was positive for polymorphism, we decided to give her a fixed dose combination of recombinant FSH to LH in a ratio of 2:1 with a starting dose of 300, which we gave for 4 days. And a scan was repeated on the 6th day. Here you can see that at least on the 6th day, most of them were synchronous, and good follicular cohort was there, which was recruited, which was not seen before. Antagonist was started on the 6th day of stimulation, and the same dose of gonadotropins were continued. When we came to day 9, we had one follicle of 16, 2, 14, 10, and in the left we had 17, 13, 12. Again, the asynchrony had already set in. We continued the same dose along with antagonist, and on the 11th day we saw that there was stagnation and there was no improvement in the size of the follicles. So we did decide that, though with a reluctant heart, but we just said, okay, let's give the HMG here. So HMG 300 with the antagonist were given for 2 more days. And then we had follicles of 20, 20 on both sides, 15, 16, 14. And we said that, yes, this is the time to give the trigger. On the day of giving the trigger, her peak estradiol level achieved was 1205, LH3, and P4 of 1.1. I decided to give her the FSH co-trigger alongside the recombinant HCG trigger. The egg pickup was performed after 35 hours, wherein we got 6 oocytes. 5 of them turned out to be mature of fair quality. My embryologist wasn't complaining, otherwise for low prognosis patient, I always have them telling, oh, the oocytes are so dark, the PVS is bad, doctor, your eggs are bad, you can't expect a good embryo. So I didn't hear many such complaints. ICSI was performed. We were successful in getting 2 blastocysts. The first blastocyst came on day 5, and we had another blastocyst by mid of day 6. However, on the patient's request, a PGTA was performed for both the blastocysts, and it was found to be euploid. Since the endometrium was thin and had some issues, we did perform a diagnostic histoscopy before the embryo transfer. Then we took her up on a HRT cycle for endometrial preparation, and a single blastocyst was transferred with a standard luteal phase support. She was found to be positive, and it was a unicornate uterus. We delivered her at 35 weeks after she came with a leak. So what I have to show here is this is how small, this was the left ovary and this was the right ovary. I was even wondering at the end of it that how on earth could we even get the eggs. It was very, very small ovaries. Otherwise, there was nothing else that was commentable on this. So on seeing this case, our understanding was that younger aged individuals should be encouraged to undergo self cycles, then jump on to donor cycles with different stimulation protocols. Probably an early start of LH may be beneficial to these patients. There is a role of testing of polymorphisms. Different trigger mechanisms can be of help, though it can't be generalized. Following this, we did adapt to using the fixed dose combination for a series of patients who have reached about 288 in our clinic, and we divided them across the Poseidion groups. We have found that in group 2, 3, and 4, in all 3, there is a statistically significant number of higher good quality embryos, though the number of eggs retrieved are not statistically significant in all groups. So perhaps there is a role to think on these. Thank you so much for a patient hearing.